Good afternoon, my name is Chariclia Paradissis and today I'm going to introduce you to Mr. MI. As a pharmacist, I have a conversation with patients like Mr. MI about medications after an acute myocardial infarction, or AMI. This is a lengthy process as there are often multiple new medications. Additionally, these patients are at risk of medication harm as they are often older, have multiple comorbidities, and high levels of polypharmacy. However, although these patients are known to have high rates of rehospitalization, the role that medication harm plays is poorly explored. So what is medication harm? It is any negative patient outcome related to medication use, irrespective of severity or preventability. In this retrospective cohort study, we investigated the incidence, type, timing, and severity of medication harm causing unplanned rehospitalization after an AMI. We use clinical coding and case mix data reports to identify those who were rehospitalized within 18 months of their AMI. Medication harm rehospitalizations were identified using clinician medical record review and clinical coding data. Severity assessments of identified medication harm were undertaken using published scales. So what did we find? There were 1,564 patients with an index AMI admission. 418 of these were rehospitalized, and of these, 89 patients were found to have 101 medication harm events. The most common events were gastrointestinal bleeds, acute kidney injury, and hypotension. Furosemide, antiplatelets, and perindopril were the most commonly implicated medications, and this matches with the common events seen in medication harm literature. In terms of timing, there was a median time to medication harm rehospitalization of 79 days, with 75% of the events occurring by the 6-month mark. Rash, syncope, dyspnea, and gastrointestinal bleeding occurred more commonly in the first 1 to 2 months of discharge. There was a greater spread in the timeline to acute kidney injury and hypertension, and this could potentially be explained by the uptitration of antihypertensives or the prescription of diuretics for patients with subsequent heart failure. The majority of events were classified as serious, and there were 8 life-threatening events, including angioedema caused by perindopril. In conclusion, the 3 key takeaways are that approximately 1/5 of rehospitalized AMI patients experience medication harm. The first 6 months after discharge is a high-risk time for medication harm and should be the focus of harm mitigation strategies. These could include empowering patients to recognize medication harm and stringent and timely monitoring. Ultimately, this study is the first step towards enhancing medication management for our patients like Mr. MI. Thank you.